So I have to do something that we haven't done before on this series.
Really? What's that?
I feel like I have to issue an apology.
My God, for what?
Or maybe a correction? Whatever it is. I committed some low-key slander, and I need to make it right.
Whoa.
And this act of misdemeanor malfeasance was in a really good episode, too. I mean, all our episodes are good, but I was particularly proud of the one I did about CAR T-cell therapy.
Yeah, I love that one.
Well, thank you. And this is Smarter Than Cancer, by the way, and I'm David Hoffman.
And I'm Hajar Eldas.
So we're storytellers, right? We're not doctors. And so when we're presenting these ideas, we're always kind of looking for narrative hooks and little ways to make the story more exciting and a little spicier. And in that one, I thought it would be a good idea to set up a kind of villain. So maybe we should listen to the tape.
Now we're seeing it for multiple myeloma. So tremendous advances.
This is particularly exciting because until this treatment came along, the only treatment available to many of these patients was a stem cell transplant in the bone marrow, which is a really difficult procedure with a famously long and grueling recovery period. This new cell therapy is not a simple procedure, and it absolutely has challenges, some of which we'll talk about in a minute. But almost everyone would agree that it's much easier on the people getting it than a bone marrow transplant would be. So that's what I said. And how would it make you feel if you heard that and then you had to get a bone marrow transplant?
Well, not good.
I know. And the truth is that bone marrow transplants aren't that scary anymore. They've improved dramatically over the past decades. They're a much safer and easier procedure than they used to be. And in many cases, they are absolutely the best course of treatment.
Well, David, it sounds like you have some rehabilitation to do.
Indeed. So we just published an episode all about CAR T-cell therapy. And I have to say that bone marrow transplant in this episode was kind of the boogeyman.
Oh.
There's a little bit of like, one of the reasons we love this and we want to do this is this will remove the need for bone marrow transplant, which is horrible and difficult and all of these things. And I'm wondering, why does it have the reputation of being onerous procedure?
Yeah, these are fighting words these
And is that
days.
deserved?
They're trying to put me out of business. No, it's okay.
That's the voice of my guide on this journey of redemption, Dr. Shernan Holtan. She's the chief of blood and bone marrow transplants here at Roswell Park.
It is actually well-deserved. The historical bone marrow transplants were very arduous, and a lot of people died of infections of this problem called graft versus host disease. We didn't have good prevention for it, and relapse, the cancer coming back despite everything. So historically, we wanted to avoid transplant because of the complications. But guess what? Transplants are actually much safer and much more effective now. It used to be that somewhere around 50 to 75% of people would have long-term immune problems. Now, the chance of having severe long-term immune problems is around 5%. It used to be that 1 year survival after a transplant was somewhere between 30 to 50%. Currently, our 1 year survival is trending around 90%.
Wow, that's fantastic.
Much better. And that is with being able to take care of people who have a lot more complications coming in. We can do this much more safely than we used to. So this breakthrough that has changed our practice has come at a time when CAR T is starting to take off. So now, we have to have a talk about what's really best sometimes, transplant versus CAR T.
To understand this amazing breakthrough, let's start with some basics. First off, what is bone marrow and why is it so important?
Bone marrow is the gelatinous part of the inside of your bones, especially your long bones. femur, kind of your larger bones in your body are filled with this gelatinous goo that makes your blood.
I think I learned that maybe in my 30s, that your bones make blood.
Yeah.
I don't think most people really understand that. We think of bones as being just like the framing of the house, but they're really active.
Very much so. So inside of the bone marrow, inside of this gelatinous goo, are these very specialized cells called hematopoietic stem cells. So these cells mature and become differentiated into all the different blood components.
Your bone marrow is mostly fat, which is creating a nice home for these stem cells, which differentiate themselves and then divide and divide and divide to make different kinds of blood cells. The red blood cells that carry oxygen and nutrients around your body, the white blood cells that fight infections and diseases, and the platelets that allow your blood to clot and close up cuts and injuries. These stem cells usually work great, cranking out an enormous amount of new blood cells in your body, hundreds of billions of them every day. But, like every other part of your body, they have the potential to get out of whack and start malfunctioning. This can make there be not enough of the right kind of blood cells in your body, which can cause all kinds of problems. It can cause absolute pandemonium in the immune system because there aren't enough white blood cells, excessive bleeding from small cuts because there aren't enough platelets, and/or because there aren't enough red blood cells. You can sort of suffocate internally, not get the oxygen from your lungs to all the places it needs to go to keep your body running.
That's absolutely a risk. So that can be a huge strain on the heart. If you're not able to carry oxygen, that's a huge stress on the body, right? You can't perform your normal daily activities.
Some of the things that can cause these dangerously off-kilter blood counts are cancers, diseases of the DNA that make blood cells reproduce too much or in the wrong way.
Here's an example. Leukemias are stem cell cancers. These are cancers of immature cells in the bone marrow. You have a growth of stem cells that can't mature, and they overgrow and completely take over the space. And that becomes life-threatening because you no longer have the normal immune function that you once had, and you also are squeezing out all of the normal components of your blood, so you are not making as much blood as you should.
With other blood cancers like lymphoma and multiple myeloma, the specific mechanism is different, but the end results are similar. Too much of some kinds of blood cells and not enough of others, preventing you from having the balance you need to keep your body running. These are big problems, and in the past, they've been very hard to treat. Because the cancerous cells are in the blood, they're moving all over your body all the time, so you can't cut them out or zap them the way you might with a regular solid tumor. So what do you do? For a long time now, one important strategy has been to replace unhealthy stem cells with new healthy ones, a transplant. This is a technique that was developed in the early 1950s by doctors who were dealing with a totally different problem: how to treat the results of acute radiation exposure amongst the people who first developed nuclear energy.
So think back to Oppenheimer. One of the main causes of death in those who were exposed to radiation but didn't die immediately from the blast was bone marrow aplasia, wiping out their bone marrow.
Wow.
And so initially this was developed as a way to overcome that acute radiation syndrome. But of course, smart people realized, we could actually use this for therapeutic benefit in cancers of the bone marrow. So in the 1950s, 1960s, this was developed more for the treatment of cancer.
One interesting thing they discovered in developing this is that you don't actually have to inject these new stem cells directly into the bones. If you just release them into the bloodstream, they'll sort of swim around and find their way to the right place.
The stem cells have a trafficking signal on them. They have this thing called CXCR4. This protein wants to bind to something called SDF1 that's found in the bone marrow. So as those cells are circulating around, when that CXCR4 finds the SDF1, it says, oh, I like it here, and it sticks. So within a few hours of giving the stem cells IV, intravenously, the stem cells have populated in the bone marrow.
So, in a way, that makes the procedure easier on the recipient than an organ transplant, because there's no real surgery involved in installing the new cells.
So the process of receiving a transplant is really not very onerous. It's just like a blood transfusion. There's no pain with that.
There can be a lot of problems and complications here, though. And the first one comes because before these new healthy cells can take root, you have to make room for them by getting rid of the unhealthy ones. They do this by kind of simulating the effect of that Oppenheimer-era radiation poisoning.
What we do to kind of make space for the new bone marrow is give often high doses of chemotherapy or radiation to wipe out their existing bone marrow.
Oh, wow.
So we're using that effect therapeutically. So this is most often 4 to 6 or 7 days of chemotherapy, depending on the recipe we use, plus or minus some radiation. Then the stem cells are given. And then from there, it's really about the recovery.
The recovery period is tricky because by blasting away the old bone marrow, you've basically removed someone's immune system. Until the new stem cells take hold and really start doing their thing, the patient is really fragile and susceptible to other problems. Replacing someone's immune system with a new one also often causes a really serious condition called graft versus host disease. Until recently, this was the main cause of life-threatening complications after one of these transplants. This is basically caused by the fact that immune cells are designed to pick fights with strangers. When they see cells they don't recognize, they attack them. So, when you put functioning immune cells into a whole new body, they're totally surrounded by cells they don't recognize. Sometimes they go berserk and start attacking everything.
Within that bag of stem cells, there are also some mature cells in there called T cells. These cells are the ones that could cause the complication that we don't want, called graft versus host disease. We put all of these cells into the patient and they start to circulate. In that setting, there's no immunosuppression, meaning I've got this fully functional new immune system that I just gave to someone. And the immune system's main job is to help fight foreign invaders. And that new immune system knows it's not in the right body. It's like, where am I? This isn't normal. Everything is foreign. And it starts to get activated. So there can be inflammatory side effects from that.
And that sounds kind of similar to some of the dangerous side effects of CAR T-cell therapy.
Cytokine release syndrome.
There you go, yeah.
Very much like it. Very, very much.
And this was really the biggest problem in these transplants historically, and the greatest factor in the terrible reputation they had. The severity of these immune responses, really high fevers and so forth, would make people so sick that it would negate any benefit the treatment had in fighting the underlying cancer. But then, really very recently, doctors discovered that by giving a single dose of a very inexpensive chemotherapy drug called cyclophosphamide a few days after the transplant, these graft versus host symptoms could be reduced by a shocking extent. This, more than anything else, has caused those 180-degree changes in the safety of these transplants.
The implementation of post-transplant cyclophosphamide, that has honestly changed our field. When the immune cells are activated, they start to divide very quickly. Dividing cells, rapidly dividing cells, can be easily killed by chemotherapy. So, we let those cells go to town. We let them throw a party. All these T cells that would be bad guys that would cause graft versus host disease are dividing like gangbusters. So then on days 3 and 4 after the transplant, I can give this cyclophosphamide, and it kills those cells that would cause graft versus host disease more effectively than any other prevention we've ever had. And then from there, what we're left with are the healthy stem cells and the immune cells that were not causing problems. Then they can fully reconstitute the patient's body, grow that new immune system, and patients do well. Historically, the hospital stay for most people was 4 to 6 weeks, and then they would have to stay near the transplant center if they lived far away for about 3 to 6 months. Today, we still do that conditioning part in the hospital. We still give the stem cells in the hospital. But if a patient is feeling well and they're well supported and live locally, they can be out of the hospital as soon as day 5. They're not in for 4 to 6 weeks in total. Now they're in for about 11 days in total. And again, if someone is well and recovering, we can get them home as soon as 28 days after their transplant, no longer 3 to 6 months. So with the increasing safety of transplant with post-transplant cyclophosphamide, with the advent of telemedicine, we can really reduce the burdens of transplant, hopefully soon to a point where people don't have to completely upend their lives, risk losing their jobs or their homes, because who can afford to move somewhere else for 3 to 6 months for cancer treatment?
This has all happened in parallel to amazing new international donor registries that do a better job than ever in matching patients with compatible donors, and also a transformation of the process of donating these stem cells, so that also no longer looks like surgery and instead looks a lot like a blood transfusion. So now the whole process is dramatically easier and safer. Finding a donor, extracting the healthy cells, getting them into the patient's system, and then getting that patient up and back to their life.
It's a beautiful thing.
So we talked about the past, we talked about the present. What do you see for the future?
In the future, I would like to come up with a transplant platform that ideally does not involve chemotherapy or radiation. Even though we've made these innovations, currently still we need to keep people under our pretty close care for a couple of months. What if I could shorten that down to be a fully outpatient procedure? We basically just swap one immune system for the other without these awful side effects. That would be amazing. So developing new conditioning regimens that are not toxic on the rest of the body would be phenomenal. I could do a transplant fully as a very safe outpatient procedure.
I mean, no promises, but do you see a route to that? Do you see biologically paths that might lead to that?
Yes, this is literally being tested right now in clinical trials.
Amazing.
I fully recognize that the field wants to come up with a treatment that will replace a stem cell transplant because it is arduous. It does take a long time to recover from. I'm delighted for that possibility. I would love to retire. I have hobbies I would love to pursue.
You could do other things.
I can. But honestly, it is still the best and final treatment that many patients will ever need. And so I think it's important to realize, even though we're seeing an explosion of new therapeutic options and new types of targeted agents in CAR T, this is all excellent. Still, at the end of the day, the best path to cure for many patients is a stem cell transplant. We currently only have CAR T for lymphoma and myeloma and acute lymphoblastic leukemia. So there's a whole lot of cancers that we just don't have CAR T treatment for. As time goes on, I do anticipate we'll develop CAR T for more diseases. This will be great. I think the real question going forward then is, will these CAR T therapies be curative? We're still actually not sure if someone can have a CAR T treatment and have it be so effective that they don't need a transplant down the road. There's no drug yet that can do what a new immune system does.
Maybe the moral of this story is that, everything I've read about the history of cancer was how challenging blood cancers were to treat for a long, long, long time. And it seems like there's a lot more options now than there ever have been, and they're increasing all the time. That's pretty exciting.
It's very true. And more people are eligible for transplants and cell therapy than realize. Currently, only about 20% of people who would be eligible for a transplant receive it. So this podcast is very important because people need to know these options exist. And we need to be talking about how the procedures are easier than they used to be. We have made it much kinder, much gentler, much more successful. If we have in our minds the old picture of what a bone marrow transplant was, that's not our reality today.
Thanks for listening to Smarter Than Cancer, a production of Roswell Park Comprehensive Cancer Center.
The show is written and produced by your hosts, Hajar Eldas and David Hoffman.
Production oversight by Peter Sosha.
Additional logistics and support from Michelle Eisenstein.
Our production partner for this series is Citizen Racecar.
Post-production by Gregory Schweitzer for DCP Entertainment.
Publication and promotion supervised by Candice Chanteloup. If you or your loved one has been diagnosed with cancer and would like to schedule an appointment with Roswell Park, please call 1-800-ROSWELL. That's 1-800-ROSWELL. Or visit us at roswellpark.org.
If you're enjoying this series, we'd love to hear from you. Please reach out and tell us about your cancer story, and let us know what topics you'd like us to cover in future episodes by filling out the form at roswellpark.org/.
And if you know someone else who might find value in what we're doing, please tell them about it. You can listen and subscribe wherever you get your podcasts.